The following podcast is part of a certified educational activity titled Individualized Treatment for Generalized Myasthenia Gravis, targeting the cause and prioritizing the patient. Access the entire activity and complete the post-test at peerview.com/SZN860. Downloadable slides and practice aids are also available.
Hello. We're going to discuss the individualized treatment for generalized myasthenia gravis, targeting the cause and prioritizing the patient in today's presentation. My name is Vera Brill. I'm a professor of neurology specializing in neuromuscular diseases from the University of Toronto, and I'm head of the neuromuscular part of the University of Toronto. So what we want to do today is improve your ability to recognize the impact of generalized myasthenia gravis on patients, provide you with updates on recent data informing the use of FcRn blockade in generalized MG, and equip you with the skills you need to incorporate FcRn inhibitors into treatment plans for appropriately selected patients with generalized MG. So beyond diagnosing MG, we need to understand the daily impact of generalized MG on patients' lives. We know that there are 4 to 30 cases per million persons per year, and the prevalence is 150 to 200 cases per million persons per year. This is from data globally on MG. So the core manifestation is fatigable muscle weakness, so weakness that is worsened by exertion, improves with rest, and only recurs again with resumption of the activity. Symptom fluctuation is a hallmark of the disease. The most common presenting symptom is ocular double vision and drooping of the eyelids, so ocular symptoms, the double vision and ptosis. But bulbar muscle involvement leads to dysarthria, dysphagia, and facial or jaw weakness. Limb muscle weakness is usually symptomatic, and proximal is the proximal muscle groups. The distal muscles can be affected in some patients, and 15 to 20% of patients with acetylcholine receptor positive MG develop respiratory weakness requiring mechanical ventilation, also known as an MG crisis. So what about the burden of the disease from the patient perspective? A qualitative study that was based on interviews with 28 individuals with generalized MG resulted in the finding that there was an average of 16 symptoms per person with MG. The most frequently was eyelid drooping, physical fatigue in 89%, leg weakness in 82%, difficulty breathing in 82%, and difficulty holding up the head in a lot of patients. The most troublesome symptoms were the blurry vision, breathing problems, fatigue, and swallowing problems. So from the patient perspective, the impacts of generalized MG include emotional impacts in all of the patients, physical impacts in all of them, and social impacts in almost all of them. The activities of daily living were impaired in more than half. Hobbies and sports were impacted in almost 90%. Planning adaptations also in almost 90%. And work, career, financial burdens in 100%, and sleep problems in a very high percentage. So the fluctuations in symptoms and severity really negatively impact emotional, social, and economic well-being of patients. This is from a study, My Real-World MG, and the quality of life is impacted in most patients. there were 679 patients in this study, and you can see the green line is not at all, the orange is somewhat, and then the darker color to the right, dark blue, is very much. And you can see how different symptoms on the y-axis impact patients to different degrees, going up to 100%. So no quality of life impairment, 0 on the scale, to 30, which is severe impairment in all domains, and a mean score of 11.5 in this study. Even when treated, and we always think of myasthenia gravis as a treatable disease, MG can remain burdensome. There was a 10-year longitudinal study of 78 patients with MG. 42% were in remission and 45% at 10 years, so not much difference. And the proportion of patients with depression and anxiety remained the same over the 10 years, but objective measures got worse. So a patient's perception of poor quality of life may persist even if the MG is well treated from a physician's perspective. The sources of patients' dissatisfaction include the delayed onset of effective various medication, the failure of efficacy of medications, the difficulty or inconvenience of treatments in about a third, adverse effects in more than a third of all treatment groups, and more than 80% had AEs if they were on prednisone. So the logistics can interfere with treatment. For example, getting plasma exchange, attending an infusion center, or needing to attend hospital for specific treatments. So we'll now come to targeting FcRn and understanding its role in immune response and generalized MG development. We know that acetylcholine receptor positive MG is the most frequent form in about 85% of patients. And these patients may have underlying hyperplasia of their thymus or a thymoma, and it is primarily IgG1 and IgG3. There is MuSK-positive MG, which is IgG4, in 7 to 10% of patients with MG, depending on the series, and up to 40% of patients who are negative for acetylcholine receptor antibodies will have MuSK antibodies. But there are other subtypes, such as LRP4 antibody positive, and then double or triple seronegative, triple meaning none of the antibodies, double meaning no acetylcholine receptor or MuSK antibodies. This is a schematic that shows the pathophysiology with the origin of the disease, we think, being in the thymus, and then the formation of antibodies, acetylcholine receptor and MuSK. MuSK helps with clustering of acetylcholine receptors. Acetylcholine receptor antibody disease acts by blocking or leading to increased degradation and internalization of receptors, and eventually to activation of the complement system and depositioning of the membrane attack complex with simplification of the postsynaptic membrane. So Fc receptor antagonists, what are they? Basically, the Fc receptor acts as a recycling system in the regular cell. So it takes IgG antibodies that enter the cell and returns them to the cell surface and the circulation. And what this does is prolong the half-life of IgG. But if you block the Fc receptor with an Fc receptor inhibitor, then you block the binding of healthy antibodies or any antibodies to the Fc receptor. And instead of being returned to the circulation, the antibodies are returned to a lysosome where they are degraded, and therefore the half-life goes down and all IgG levels go down. So we have reviewed the action of FcRn, and we know that blocking the FcRn targets antibodies that drive myasthenia gravis. FcRn recycles IgG and extends its half-life by about 4 times, therefore increasing the availability of IgG autoantibodies such as the acetylcholine receptor. FcRn targets IgG autoantibodies with greater selectivity than conventional MG treatments such as corticosteroids. The more broadly suppressive therapies may also be inadequately effective, burdensome, or reserved only for refractory MG patients. So we have 2 FDA-approved FcRn antagonists for generalized myasthenia. The first one is Efgartigimod, an IgG antibody fragment, approved for use in acetylcholine receptor positive disease, given intravenously or now subcutaneously. It is given weekly for 4 weeks and then again, depending on the clinical status of the patient. Rozanolixizumab was approved more recently. It is a monoclonal antibody that has been approved for both acetylcholine receptor antibody positive and MuSK positive disease. It is administered subcutaneously. It is given weekly for 6 weeks and then is deemed clinically indicated. ADAPT was the phase 3 trial of Efgartigimod. There were 167 patients who were acetylcholine receptor antibody positive in generalized MG classes 2, 3, or 4. They had to have a myasthenia gravis activities of daily living score of 5 or more. They had to be on stable doses of standard of care treatment. The primary outcome was a 2 or greater point improvement in the ADL score for 4 or more consecutive weeks. The patients were randomized 1-to-1 to Efgartigimod intravenous infusion, 10 milligrams weekly for 4 weeks, or placebo. And this shows the ADL responders that were 67.7% in Efgartigimod compared to 30% in placebo, and the QMG, which was a secondary endpoint that had to improve by 3 or more points, improved in 63% of Efgartigimod patients compared to 14% of those on placebo. Interestingly, 84% of patients who responded to Efgartigimod did within the first 2 weeks of treatment. So this result in the phase 3 trial led to approval of Efgartigimod by the FDA. The outcome was based on only acetylcholine receptor positive patients who had completed 1 cycle of 4 weekly infusions. However, there is a repeatable and sustained improvement over multiple cycles, as shown by these graphs that show the ADLs on the left and the QMG on the right, that shows the decline after starting the treatment, decline meaning improvement, and then the slow return to baseline after the treatment, after the 4 weeks of infusion. There was a 3-year open label extension study to look at the safety, tolerability, and efficacy. 90% of the patients who completed the phase 3 study enrolled in the open label extension, and there was consistent, repeatable reductions in IgG levels with repeated treatments, and the improvements in the ADL and quantitative MG scores mirrored the reductions in total IgG and acetylcholine receptor antibodies. The long-term treatment with Efgartigimod was well tolerated and efficacious, and no new safety signals emerged, which was highly reassuring with a drug that drops IgG levels but the safety signals did not change with prolonged repeated treatment. So the most common adverse effects were headache, concomitant COVID-19 infections, nasopharyngitis, diarrhea, and urinary tract infections that were mild to moderate. MyCaring was a phase 3 trial of Rozanolixizumab that enrolled 200 patients. They had to be acetylcholine receptor or MuSK positive. Some were seronegative. The ADL score had to be 3 or greater at enrollment, and these symptoms in the ADL had to be non-ocular, and the quantitative MG score, QMGS, had to be 11 or greater. The patients were randomized in a 1-to-1 ratio of rozanolixizumab subcutaneous infusions of 7 or 10 milligrams per kilogram or placebo weekly for 6 weeks. And the primary outcome was a change from baseline in MG ADL score. This shows you the reduction in ADL with the two lower lines on the left being the 7 and 10 milligram per kilogram doses of rozanolixizumab and the top line being placebo. And the QMG is shown in the graph to the right, again with a similar lower curves showing improvement in those on rozanolixizumab compared to those on placebo. The long-term safety of rozanolixizumab has been studied in pooled data from the pivotal phase 3 study of MyCaring and the open-label extension. Most of the adverse events were mild to moderate in intensity. Headache and GI AEs were more frequent in cycle 1 than in subsequent cycles. The incidence of other treatment-emergent adverse events was consistent across cycles. 8 patients, or 4.3%, had severe headaches and serious infections. One case of serious aseptic meningitis led to the patient withdrawing from the study. So there are investigational FcRn antagonists in phase 3 trials. One is Batoclimab, which has enrolled acetylcholine receptor positive and MuSK positive and LRP positive patients as triple negative patients as well. And the route of administration is intravenous, and the frequency is given every 2 weeks. Batoclimab has the 3 antibody-positive groups of patients, is given subcutaneously, weekly initially, then every 2 weeks. So the phase 3 results on Batoclimab were presented earlier this year. There were 199 patients, 153 were seropositive and 46 seronegative, randomized 1-to-1 to standard of care plus placebo or standard of care plus Batoclimab, which was 30 milligram per kilogram IV loading dose, then 15 milligrams per kilogram every 2 weeks thereafter. The primary outcome was change from baseline in the ADL score, which is shown to the left. The mean score decreased by 4.70 points from baseline with Batoclimab versus 3.25 points in placebo, which was significant. And the mean QMG scores decreased from 4.86 in the 4.86 from baseline with Batoclimab compared to 2.5 with placebo, as shown to the right. The ADL responder rate is shown here at different weeks, and you can see that it is higher with Batoclimab than it is with placebo at all those time points shown below. And the safety is similar to other FcRn inhibitors. There were similar treatment emergent adverse events with Batoclimab and placebo. There were serious AEs, a little more in placebo, headache, muscle spasms, COVID, infusion reactions, and peripheral edema, as shown there. Some of these more prevalent in placebo than nipocalimab, and vice versa. So the phase 3 efficacy and safety of Batoclimab in generalized MG is a 9-week multicenter randomized trial conducted in China. Patients had generalized MG classes 2 to 4. The ADL score had to be 5 or greater, and less than half of the points could be derived from ocular muscle weakness. And the patients had to be on a standard care of treatment at a stable dose. The patients were randomized 1-to-1 with placebo or batoclimab subcutaneous injections at 680 milligrams weekly for 6 weeks, and then observed for 4 weeks. And the primary outcome was a 3-point or greater improvement in ADL for at least 4 consecutive weeks. And we see the ADLs shown here with the placebo, the upper curve, and the batoclimab, the lower curve, showing a significant separation between the two. So 58% had sustained improvement in ADLs with the drug compared to 31% in the placebo. The AEs, treatment emergent adverse events, were more prevalent with batoclimab than placebo, and severe AEs were similar. So now we've reviewed the studies on FcRn receptor inhibitor treatments, those that have led to approvals of 2 of them, and those that are still being investigated but have positive trial results. What about the patient treatment needs for the management of generalized MG? We know that the MGFA task force laid out goals of treatment in generalized MG. We want a post-intervention status of minimal manifestation status or better, meaning almost no MG, ADL of 0 or 1, really. Treatment-related AEs should be absent or very mild, and remission is defined as no signs or symptoms of MG. We can tailor FcRn treatment plans for patients with generalized MG. We can consider FcRn inhibitor use as an alternative or adjunct to long-term corticosteroid use in generalized MG treatment. The goal would be to reduce or eliminate the reliance on steroids, especially in those patients at risk for steroid-related adverse events, which are many. We can select appropriate treatment options based on disease severity, comorbidities, myasthenia gravis subtypes, and other individualized factors. There are challenges and considerations in transitioning or combining therapies while we aim for steroid-sparing goals. We may upset the status of the patient as we transition to other therapies, and we have to be reassuring to our patients if we take this course. And what are the patient considerations in treatment decisions for generalized MG? So there are practical strategies for initially assessing and then monitoring treatment response and AEs. You have to determine when you're going to administer the subsequent rounds of treatment. I mentioned with Efgartigimod and Rozanolixizumab that there was the initial cycle of treatment, either IV for 4 weeks with Efgartigimod or subcutaneously every week for 6 weeks with Rozanolixizumab, with subsequent treatment cycles depending on the status of the patient, how long the benefit lasted if they had it, and when they should be retreated. There's the shared decision-making to give an individualized approach to treatment. Most patients want to come off steroids. Most patients would like something new that improves their status. But not everybody wants regular IV treatments. Not everybody wants regular subcutaneous treatments. So it's important to have the patient as a partner in making these decisions. There's a reduction of potential infections associated with FcRn inhibition. So you have to be aware of the risk, that there is a risk, small, but there is a risk. Then there's vaccination scheduling. When do you give vaccination in association with these new treatments? And pregnancy risks, because all the studies exclude pregnant women. And safety and site considerations. There must be an allergy and anaphylaxis protocol because infusion-related reactions can occur. You have to know how to manage anaphylaxis, and you have to follow the policies of your organization. Site of care considerations, the geography. Are you going to go to an infusion center or have treatment at home? Is there availability of emergency support staff? Is there caregiver support? How mobile is the patient? What is the biological history? How easy is their venous access if it's intravenous? There are risks associated with a first dose. And is the patient going to be adherent to treatment? All of these are very important. So our next topic is incorporating the patient perspective in the management of their generalized MG. It is not the physician's disease, it's the patient's disease. So the patient has to have a role in management. So shared decision-making with our patients is outlined here. The S can refer to seeking out and encouraging patient participation. Patients are learning a lot once they know they have generalized MG. They're learning about the disease, they're learning about autoimmunity, they're learning that we don't cure autoimmune diseases but control them. So the patient has a chronic disease, they have to buy into their therapy, and they can do that if you discuss all the elements of the disease and give them time to adjust to the knowledge they have it. We have to help the patient explore and compare treatment options in a realistic and fulsome manner. It's very difficult to lay out all the steroid side effects and have a patient happy to start using corticosteroids to control their disease. And yet, if they don't have coverage, they may not be able to afford modern treatments. And some of the treatments take so long to start working. So the patient has to understand there are different treatment options. You have to help them understand those options. And then we have to assess individual patient values and preferences. Some patients may be more willing to access intravenous therapy periodically, and others may prefer to be on pills such as corticosteroids. So you have to understand your patient, where they're coming from, and what they want to do. Then you have to, having done these elements, reach a decision with the patient. Because if the patient doesn't agree with you and they don't tell you, they just won't follow your treatment when they're home. And afterwards, you have to evaluate your patient's decision. So it's a drawn-out process and takes several visits after the initial diagnosis for the patient to come to a more fulsome understanding of what's going on, what they can do about it, what they want to do about it, and what they will agree to. Patient-centered care means sharing the goals for health and prioritizing those of the patient, understanding the comfort level the patient has with the process, what their underlying capabilities are. So if you're going to go for subcutaneous injections, are they going to accept that? What are the barriers they may have to adherence or to following your instructions? What the changes are from baseline, good or bad? Have they got worse? Have they got better? Have the developed AEs that are interfering with their overall status, and following up with the patients on all these elements to know where they are. Are they still with you? Are they with you to begin with? Are they still with you? And are they following a treatment plan as well as you would like? The patient's assessment of their treatment can be very different from a physician's assessment. There was an online survey conducted by MG News. 743 people responded. 90% had MG. And if you look at the easy graph below, 71% were extremely or somewhat satisfied with their treatment plan, meaning 29% weren't. But only 44% were very or somewhat satisfied with their quality of life. So that's very discrepant, meaning they were feeling better with respect to their disease, but not with respect to their quality of life. This slide shows patient sentiments about their MG treatments. It was a qualitative study with an AI-generated voice analysis of 11,500 posts from more than 8,000 individuals discussing their appearance with MG. It shows different treatments that they had and their satisfactions with them. Green means they're satisfied, the gray is neutral, and the orange is dissatisfied. And you can see that not very many people are satisfied with a long green line. In fact, very few are satisfied with whatever treatment you put up there. We have to do better to get beyond this. So we're in a new era of treatment for patients with generalized MG with Fc receptor inhibitors. These act very quickly and have the potential to reduce the dependency on corticosteroids that many patients with MG have, and therefore reduce the burden of the steroid side effects. The one issue might be cost of treatment. That would be addressed by the insurance coverage that the patients have, but we're in a far different era now than we were before the development of Fc receptor inhibitors.
Thank you for listening. Remember to download the slides and practice aids and complete the post test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC, which are both Johnson & Johnson companies. To access all materials for this activity, visit peerview.com/SZN860.